Good afternoon, everyone. My talk is on cardiac complications of chemotherapy. Objectives for this talk: I'm going to describe cardiotoxic effects of some specific cardiovascular related toxicity of specific agents. Then we're going to talk about monitoring strategies. What do you want to do to monitor those patients who are at risk? And at the end, I'm going to focus on how you can help them go through the toxicity once they develop toxicity. What kind of cardioprotective strategies can you implement? And disclosures for this talk are none. Cardiotoxicity is secondary to chemotherapy. It can be acute or chronic or both. It can increase morbidity and mortality or both. It ranges from dose-dependent irreversible damage to dose-independent reversible damage, and we'll talk about it in detail later on. And at times you have to interrupt the therapy, or other times you may have to stop therapy because you have no other alternative. So this table outlines potential cardiotoxic complications, cardiotoxic effects of chemotherapy. It includes LV dysfunction and heart failure, arrhythmias, prolonged QT interval and sudden cardiac death, ischemic heart disease, pericarditis with or without effusion, hypertension, hyperlipidemia, and thromboembolism. For example, thalidomide, which we use for multiple myeloma, is notorious to cause thromboembolism. Out of all this, one of the most serious complications known to cardiologists and oncologists is LV dysfunction and heart failure. In most studies, it's defined as at least 10% drop from baseline to an absolute value less than 53%, or at least 15% drop from the baseline. There are different definitions used when they did studies, but these two are widely accepted. In fact, the first one is recently accepted by American Society of Echocardiography. They have published a consensus statement for this kind of patients, and they have decided to use this definition. When we talk about reversible, partially reversible, and irreversible damage, they have used these definitions also. Reversible is when EF improves to almost close to 5% from the baseline. Partially reversible is when EF improves, but it's still more than 5% from the baseline. And totally irreversible is it does not improve even more than 10%, and it's definitely more than 5% from the baseline. So these are different variations that have been used in studies. But as I said, one of the most serious and well-known complications of chemotherapy is LV dysfunction and heart failure. So I'm going to go into individual agents, and we'll talk about it, their characteristics and what are the risk factors and so forth. So anthracycline cardiotoxicity is well known to most cardiologists and most oncologists. It's widely accepted. It's studied in depth. Anthracycline is one of those agents we use for lymphoma treatment, leukemia treatment, sarcoma treatment, breast and lung cancer treatment. It can cause acute toxicity, which includes pericarditis, myocarditis, some arrhythmias, LV dysfunction, and heart failure. However, the most serious one is the chronic toxicity, which is LV dysfunction and heart failure, and most of the times this is irreversible. Some characteristics include acute toxicity is usually rare, but if it does occur, it's transient. So that's not something we really worried about. The chronic toxicity, which could be early onset or late onset, that's the one we worried about, because early onset can start during the therapy or soon after the therapy within first year. And the late onset can occur anytime 1 year after the therapy was completed. And the most striking characteristic of this toxicity is that it's dose dependent. How much dose patient received is very important when it comes to anthracycline related cardiotoxicity. When it goes more than 550, it's very high risk. Almost close to 40 to 50% patients get cardiotoxicity if you use high dose chemotherapy, including the anthracycline. And as I said before, it is progressive and irreversible. So you may have exposure right now and the symptoms may occur down the road. That's why you have to keep that in mind, and if patient has any kind of symptoms down the road, you have to suspect this in the differential diagnosis. Risk factors. Female sex at higher risk. Prior mediastinal radiation is also one of the risk factors to develop cardiotoxicity. Extremes of age, so pediatric patients and elderly are at risk. Underlying cardiovascular disease, anyone with already pre-existing cardiovascular risk factors, diabetes, hypertension, aortic stenosis, coronary artery disease, already having a low EF from whatever reason, that increases the risk. Concomitant agents, that's very important, and we'll talk about it as I talk about those three agents. Paclitaxel, cyclophosphamide, and Trastuzumab. If you combine those medications, the risk is high. Why we need to know about these risk factors? Because if you have a patient who's going to be at high risk, you can start talking about it in advance. You can discuss with patient, you can discuss with oncologists, and maybe you want to do very close follow-up if you do decide to give the drug, or you can even discuss about alternatives, because you don't want to deal with the irreversible damage down the road. So that's why you really need to know who's going to be at high risk. How does it occur? Now, when it comes to pathophysiology, for all these chemotherapy agents, we really don't know how the cardiotoxicity occurs. There's some speculation, there's some some hypothesis generated based on studies they have done. When it comes to anthracycline, it is thought that it comes from oxygen free radical direct toxicity to myocytes. And it also leads to inhibition of topoisomerase 2 inhibition. And that can lead to direct myocardial toxicity, and that toxicity leads to irreversible damage. That's very important to know, and there is cell death after that damage as compared to other toxicity that we're going to talk about. So Antimicrotubules, paclitaxel and docetaxel, they are used in breast and ovarian cancer. What they cause asymptomatic bradycardia, which is one of the common side effects, and usually self-limited. Other toxicity includes heart blocks and ventricular tachycardia, maybe SVT, for example, atrial fibrillation, atrial flutter, LV dysfunction and heart failure, particularly when they are used with other drugs, as we talked about it before, myocardial infarction and hypertension. Those that are underlined, those are the most important ones. Those are the most common ones at the same time. Characteristics, LV dysfunction and heart failure usually occur when you use this drug along with anthracycline or Trastuzumab. When you use this drug in isolation or with other agents, not including these two agents, it's very unlikely that it would lead to LV dysfunction. You may still have other complications, but it's very unlikely to have LV dysfunction. Pathogenesis, it is thought that it increases doxorubicin levels. When you give this drug with doxorubicin, it increases the level, and that leads to toxicity causing LV dysfunction and heart failure. There was also concern how come he has more arrhythmia compared to other drugs, and they found that the carrier they used to give this drug, that carrier causes some histamine release, and the histamine release leads to arrhythmia. So some oncologists, they routinely give some antihistaminic before they give infusion of this therapy to knock that histamine effect out. Next one is Trastuzumab. It's a monoclonal antibody, and it's used in HER2-positive breast cancer. We all know that. The commonest cardiotoxicity with Trastuzumab is LV dysfunction and heart failure. It is not dose-dependent compared to doxorubicin. Also, it's more likely to cause asymptomatic decline compared to doxorubicin, which is more likely to cause clinical heart failure. And it occurs usually during the active treatment, not after the treatment. So you have to be careful when you give Trastuzumab, and you have to keep that in mind. And it's reversible. Doxorubicin, as I said, is irreversible, but Trastuzumab cardiotoxicity is potentially irreversible in 80% of cases. In fact, it comes back, EAF comes back to normal within few months after the therapy is discontinued. Risk factor, again, we need to know this so you can plan in advance. Somebody with already having pre-existing risk factors, age more than 50, obesity, pre-existing hypertension, pre-existing LV dysfunction from whatever reason, and other agents that you're going to use along with Trastuzumab, you have to keep that in mind. That person is going to be at high risk. How does it occur? Pathogenesis. Inhibition of HER2 signaling in myocyte leads to injury. I repeat, there is no myocyte loss compared to doxorubicin. In doxorubicin, once you start having cardiotoxicity, you're talking about losing myocyte. Here we are talking about damaging myocyte, not losing myocyte, and that injury can be corrected if you stop the therapy and watch the patient closely. In 80% of patients, it's reversible. And second possible pathogenesis is drug-to-drug interaction. If you give Trastuzumab first, you're injuring myocyte, and then you give doxorubicin, those injured myocyte not going to do well with doxorubicin. So you want to reverse the way you give medication. Most time we do doxorubicin first and then institute Trastuzumab to avoid that cycle. Okay. Next one, Sunitinib. This one is used in metastatic renal cell cancer. Is tyrosine kinase inhibitor. But it's not very specific when it comes to inhibiting tyrosine kinase. There are a bunch of tyrosine kinase out there. This is not a specific one. So it affects not only cancer cells, but it affects other cells too because it's not specific. And that leads to cardiotoxicity. Commonest cardiotoxicity is it causes hypertension, LV dysfunction, and heart failure. Other non-cardiac toxicities is thyroid dysfunction. Characteristics, as I say, hypertension, CHF usually occurs within few months of starting therapy, usually first 3 months. And any risk factor, particularly those hypertension, CAD, obviously put that person at high risk. How does it causes this toxicity? Well, it causes inhibition of vascular endothelin growth factor, and that is notorious to cause hypertension. All those non-specific tyrosine kinase inhibitors, when they affect VEGF, they are notorious to cause hypertension. Now, that hypertension already putting myocyte at risk, and other possible pathogenesis, for example, decreasing in nitric oxide or activation of renin, angiotensin, and aldosterone axis, all that lead to very significant impact, causes very significant impact on the myocyte, and leads to myocyte apoptosis. So there is cell death here, and eventually LV dysfunction. Next one. 5-fluorouracil, antimetabolite. It's used in colorectal and head and neck cancer. It's notorious to cause acute chest pain syndromes. It can cause EKG changes, SCT wave abnormalities. It can mimic actually, as I said, acute ACS, acute coronary syndrome. It can lead to arrhythmia, thromboembolism, and hypertension. But the one that we really worried about is the presentation, acute chest pain syndromes. Characteristics, incidence is anywhere 1 to 18%. Occurs early, within few days, particularly within 3 days of starting therapy, you can have this kind of toxicity. Symptoms resolve if you stop the drug. Most likely symptoms going to go away within 48 hours. But during that time period, you have to treat that patient like any ACS person. Re-challenge. Let's say patient recovers, there is no significant damage, and you think about restarting it, you have to worry about it. Because re-challenge would reproduce similar pattern toxicity that patient has before. So most oncologists do not prefer to re-challenge 5-fluorouracil again once you have acute coronary syndrome once. Risk factors, anyone who gets the high dose continuous infusion. So it's not lifetime dose, it's the one-time high dose that causes more toxicity. And also pre-existing any CAD or prior radiation would put that person at high risk. What is the pathogenesis? They think its most commonest cause of this acute coronary syndrome is vasospasm. For whatever reason, we don't have clear understanding, but 5-fluorouracil causes severe, significant vasospasm, and that leads to acute coronary syndrome. So there did some study, they give some anti-anginal before giving chemotherapy, and they thought they would improve it, but that did not work out. That did not work in favor of patients. So the treatment is still the same. You give 5-fluorouracil, watch them for acute coronary syndrome, and if they do have it, you have to treat them like any ACS patient, including some nitrates to control that vasospasm. But giving before has not shown to improve the outcomes. Cisplatin cardiotoxicity. It's used in testicular cancers. It's also used in head and neck cancers. Acute toxicity includes QT prolongation, SVT, chest pain syndromes. Chronic one, which is more significant, is hypertension, diabetes, hyperlipidemia, and premature CAD. So those patients who's getting this chemotherapy can have down the road premature CAD because, for example, testicular cancer patients, they're going to be young patients. They get this chemotherapy and down the road you have to worry about them getting premature CAD from the effects of this drug. It's dose dependent. Cardiovascular events occur a decade after treatment. Obviously, cardiovascular disease is a chronic process. There is a latent phase, but it's still premature for that age group. It's 2 times higher than the age group, similar age group having no chemotherapy on board. Re-challenge reproduces to toxicity, particularly the acute toxicity. So again, you have to worry about re-challenging with this drug. Even they have good benefit earlier, you want to try again, but then you have to back off because they may reproduce those toxicity. Risk factors. When you combine this with etoposide, or if you start that after radiation, or anthracyclines, and particularly elderly patients, you are more likely to get all this acute and chronic toxicity. What's causing it? It upregulates intracellular adhesion molecule, and it also induces platelet aggregation. And those pathogenesis factors leads to endothelial dysfunction, which is the early step, most early step in CAD. And that early step eventually leads to premature CAD. Next one is cyclophosphamide. It's used in patients who are going for stem cell transplant. It causes pericarditis or pericardial effusion. Myocarditis is very pathognomonic. When it comes to hemorrhagic myocarditis, it's very pathognomonic to cyclophosphamide. Even though it's rare, it's one of the serious complications of cyclophosphamide. Characteristics is dose, individual dose related, not lifetime dose related like doxorubicin. And it occurs within few days. So you give first dose and you expect if it is going to occur, it's going to occur within few days. Risk factor, anyone who got anthracycline or getting anthracycline, prior radiation or advanced age. Because we're talking about these people already having some myocardial problem to begin with, and then you give drug and they don't handle it well. So what causes it? Hypothesis is that it causes direct injury, endothelial injury, causing interstitial edema and then hemorrhage, or it can cause vasospasm, or it can cause intracapillary microemboli, and that eventually leads to small myocardial infarction, heart failure, and all that. There is myocyte cell death, and obviously eventually leads to LV dysfunction. Androgen deprivation therapy. We use this medication for prostate cancer. There are 2 sets of them. One is antiandrogen and the other is GnRH, gonadotrophin-releasing hormone agonist. So these medications, they increase the incidence of dyslipidemia, eventually leads to insulin sensitivity and insensitivity, I'm sorry, there is a typo, and atherosclerotic cardiovascular disease. And what does it cause? As I mentioned, it causes dyslipidemia and insulin resistance, and that leads to CAD. Obviously, those who are at age 65 or above are going to be at high risk. And obviously, pre-existing CAD, would, if you take these drugs on top of that, it would make it worse. What happens? Insulin resistance and dyslipidemia occurring under the effect of these medications increases the body adiposity and leads to CV morbidity and mortality. Okay. Tamoxifen, we know that we use this in breast cancer patients, usually as an adjuvant therapy, early stage estrogen receptor positive breast cancer. It is associated with increased risk of thromboembolism. What does it cause? It's a mixed agonist and antagonist, and it upregulates insulin growth factor and TGF-beta. And all that leads to, even though you think this is agonist, antagonist, the final effect is it leads to thromboembolism. So that's one thing you have to, just like it's giving estrogen to someone, you are increasing the risk of thromboembolism. Giving someone tamoxifen, you're increasing the risk of thromboembolism. So I'm going to focus predominantly on LV dysfunction because, as I mentioned, it's well known, well studied. It's the most serious complication that you can get if you receive cancer chemotherapy. And depending which drug you have, the incidence varies. Doxorubicin incidence is anywhere between 3 to 26%. Cyclophosphamide, we talk about it anywhere between 7 to 28%. Docetaxel, 2.3 to 8%. Herceptin, which is Trastuzumab, we talk about that too, is anywhere between 2 to 28%. Those plus signs, it gives you frequency of use, so these drugs are frequently used in clinical practice. Okay, one sign is more than 1,000 and three sign is, I'm sorry, one sign is less than 1,000 and three sign is more than 5,000 per year. So you can imagine how many patients are getting those drugs. And the last one is Sunitinib. We talk about is renal cell cancer patients, and it can lead to anywhere between 2.7 to 11% incidence of LV dysfunction and heart failure. So some physicians have put these medications into two groups depending how they react. And they call it type 1 toxicity and type 2 toxicity. Type 1 toxicity is mainly defined by what happens when you take doxorubicin or similar drugs. And it leads to, as I said, irreversible damage, and if you re-challenge it, it's definitely going to cause more problem. The other one is type 2. Trastuzumab is reversible damage. There is no cell death. If you do biopsy and electron microscopic examination of that biopsy, with doxorubicin, you're going to get cell death, apoptosis and all that. With the Trastuzumab, you're going to see more injury, but you're not going to see cell death. So Trastuzumab, type 2 toxicity, if you stop therapy, 80% of patients may recover, and after recovery, you may, if they responded very well, initially you may consider re-challenging. But the type 1 is no-no. They're not likely to recover, and even if they recover, if they are lucky enough, if there was mild damage and they recover, and if you re-challenge them, you're taking a big risk with the type 1. And they have divided, so type 1, as I said, of anthracycline and mitoxantrone, which is one of the kind of analog for anthracycline. And the type 2, the classical one, is Trastuzumab and other tyrosine kinase inhibitors that causes type 2 toxicity. Why we are worried about this cardiotoxicity? And this is the graph that explains the reason we are worried about. Doxorubicin toxicity carries a worse prognosis, unfortunately. You can compare other low EF patients with doxorubicin low EF, and you can see peripartum cardiomyopathy has better outcome. Idiopathic cardiomyopathy has better outcome than doxorubicin. Doxorubicin cardiotoxicity outcome is as bad as ischemic cardiomyopathy. That's why we worried about. That's why, as I say, this is one of the serious complications you can get if you are unlucky and you are on doxorubicin and you get cardiotoxicity. And it's about 50%, 5-year mortality, a little more than 50%. So that's why we worried about it. And that's why we need to talk about prevention and screening strategies, and once you have dysfunction, what do you want to do? So long-term monitoring, that's why I put it here. This is the reason you need long-term monitoring of these patients, because once, when they did biopsy studies on this doxorubicin patient, they found right after first dose, you started having damage to myocyte. It may not be significant enough to clinically be evident, but right after first dose on electron microscopic exam, you have damage to myocyte. And as you can imagine, you get more dose, and the cumulative dose eventually may lead to a significant toxicity, which may become clinical toxicity. So how do they present? If they do develop heart failure, obviously from damage they go to asymptomatic phase, and from asymptomatic phase they go into clinical heart failure. So if they develop clinical heart failure, what are you going to expect? And I'm not going to go into detail because we know very well how heart failure patients present. They may have symptoms of short breath or fatigue. They may have peripheral edema, pulmonary congestion, orthopnea, and PMD. At times they present with arrhythmias. There may be initial presentation, may be arrhythmia. You do physical exam and you find heart failure. And on physical exam, you're going to have RELs, pedal edema, S3, S4, cool extremities, and tachycardia if it is really bad. How do you diagnose? I always say heart failure is a clinical diagnosis. It's not a pathological diagnosis, it's not an imaging diagnosis, it's not a lab value diagnosis. Heart failure is a clinical diagnosis. You have to combine everything you have, the history, physical, chest x-ray, labs, and then you make a diagnosis. It's a clinical diagnosis. That's why you need all together. If you haven't had an echo by this time, during the monitoring that we're going to talk about, you can diagnose that by doing an echo or MAGA scan and see the LVEF. Also, you have to, you don't want to keep a narrow tunnel vision. When you evaluate chemotherapy-induced cardiotoxicity, you have to rule out other causes. A lot of these patients may be in middle age and elderly patients, and you want to make sure there is no other underlying coronary artery disease or anything else going on that may explain the cardiotoxicity. So you still have to do workup for other possible possible causes of low EF. But this is how you diagnose. Heart failure has to be diagnosed on clinical grounds. You can supplement with other information, but not single. You cannot use only one thing. So what do? You start the therapy, you think this patient is going to be high risk, or you don't think this patient is going to be high risk, but the drug itself carries the high risk. You need to monitor them. There are few things you can do to monitor those patients. You can do baseline evaluation, and certain time period during the course you can do evaluation again to make sure EF has not dropped. Because if you catch EF before they develop symptoms, you have a chance to stop therapy and institute some medication that we're going to talk about. So there are three ways you can follow this patient, monitor this patient, screen these patients. One is echo, second is MAGA scan, which is multi-gated nuclear scan, or MRI. The modality of choice by all the consensus documents is echo. It's non-invasive, easily available. You can get a lot of information, not just pumping information. You can get information about pericardium, you can get information about valves, you can get information about right heart. So it's very important. At some centers they use myocardial strain and strain rate. That can help you pick up damage even before the LVEF drops in between. So from the damage to asymptomatic phase and clinical phase, while they're in asymptomatic phase, myocardial strain and strain rate can help you pick up asymptomatic patients with myocardial damage. MAGA scan is accurate, is reproducible because it's counts dependent. So it's reproducible, but it's associated with radiation exposure, and obviously it's not like echo. It doesn't give you a lot of information about other heart structures. MRI is not widely considered as a gold standard. It's not available at a lot of places. Even if it is available, it's time consuming, it's expensive, and a lot of people can have problem with the machine itself, and you have to worry about that too. So MRI is not widely used. The most common modality which is suggested by consensus document is echocardiogram. Endomyocardial biopsy, there was a time in 60s and 70s we used to diagnose doxorubicin cardiotoxicity by doing endomyocardial biopsy, but it is sensitive, and some people still consider it is a gold standard for particularly the doxorubicin toxicity. But as I said, you can have damages even before you have any clinical or echocardiographic evidence of LVEF drop, because it's so sensitive. It picks up the electron microscopic damage into myocyte. So you don't know what to do with that. Should we stop therapy? If you're not going to use cumulative dose more than 450, is it worth continuing? And all that comes into picture. So it's not routinely done anymore. When you have really doubt, echo is not good, MAGA is not helping for whatever reason, then if you strongly suspect the patient may have anthracycline related cardiotoxicity and you want to diagnose it, you can do endomyocardial biopsy and confirm that, and then make decision based on that. Obviously it's invasive. There's 1 or 2% chances of major complication. So that is not routinely considered in screening modalities for these patients. Whatever you use, continue that one, because inter-observer variability is going to cause a lot of problem. Inter-taste variability is going to cause problem. So you use echo, then continue echo. Use MAGA, then continue MAGA. It's very important that you do that. So what are the things that you can do on top of the monitoring of LV function? We talk about it. One more thing you can do is biomarkers. You can check biomarkers and find out who are those patients who are going to be at high risk of developing heart failure down the road. And all those patients, any patient on chemotherapy, particularly doxorubicin, they are considered type A, by the way. Patients on doxorubicin therapy considered CHF class A, even though they are not having any problem, because that's how significant relation they have. You know, the guidelines related classification A, B, C, D. Anyone on doxorubicin falls right right away in type A, heart failure. And that's why you have to monitor constantly. All the risk factors has to be aggressively controlled, no matter what therapy they are on. So let's talk about role of biomarkers. How can biomarkers help us? And there are some small studies done. One of this is this study in which they have 703 cancer patients, all kind of different cancers on high dose, different chemotherapy agents. And they used troponin I. They measured troponin I soon after chemotherapy and a month after they completed the initial course of chemotherapy. They also did echo along with the troponin check at 1 month, 3 months, 6 months, and 12 months. And what they found, the two commonest events were CHF, either clinical or asymptomatic. And they used value 0.08 or more than that as positive. And these were the findings. In 495 patients out of 703 patients, there were negative troponin before and after. Negative troponin before and after chemotherapy. 145 patients had positive troponin before therapy, but at end of the course they were negative. And remaining 63, they have positive to begin with, and end of the course it still continued to be positive. Okay? And what did they find when they follow this patient for almost close to 42 months? They found those patients with both negative, they did just fine. They didn't have cardiovascular events. But those who were positive before and after, troponin I positive before and after chemotherapy, they did not do well. They have cardiovascular events, which includes the asymptomatic heart failure and clinical heart failure. And in those patients, if you look at this graph, those patients with both positive likely to have significant drop in LVEF. More than 15% in this group, it was statistically significant. More than 25% in some patients, and some patients even have more than 50% drop in baseline LVEF, and most of those patients were those positive troponin I patients. So you have an option to risk stratify these patients. Particularly if you think some patients going to be high risk, you may want to do that. See if the troponin is high at the beginning and at the end, and if that's the case, you know this patient is heading towards the wrong way. So there is one more option here on top of the regular screening you do with echo. Because that's what they did. They also continued the echo screening in these patients. Okay. This is another study. 251 women with breast cancer received Trastuzumab, and they follow cardiac troponin I. They measure before and after each cycle. They evaluated LVEF on a routine basis every 3 months and 6 months after the treatment. And if the toxicity occurred in some patients, they stopped the drug and they started therapy with enalapril and Coreg. It's very important to understand. So if there is no toxicity, they continue to monitor them. If they develop toxicity, you stop drug and start therapy. So what did they find? So out of 251 patients, 209 patients did not have Trastuzumab-induced cardiotoxicity. But among those patients, 5% have positive troponin. So you can still have it, but most likely you're going to have no toxicity if your troponin is negative. Those who developed Trastuzumab-induced cardiotoxicity, which are 42 patients out of 251 patients, 62% of those patients were positive. And they followed this 42 patients, and this is the graph showing their outcome. Out of those 42, those who did not recover after drug was stopped and started on therapy, all of them were positive. Only 9 out of those 42, even though they were positive on therapy, they recover. So what does it tell you? If you use this, not only you can predict who's going to be at risk of cardiotoxicity, but you also can predict who's going to more likely to respond. So that is one advantage of using non-invasive biomarker, for example, for this study. So if they are positive to begin with, they're going to more likely to have toxicity and more likely not to respond medical therapy. So you can risk stratify some of these patients. It's very important. So based on these trials and some small trials and all that, recently a consensus document was published by American Society of Echocardiography. Again, There are no guidelines out there to define how to manage these patients. This is the first consensus document we ever had in first time that I know of, okay? We didn't have any consensus document. There are some guidelines, but those are for pediatric patients. So we have extrapolated some data from pediatric patients and we were using it so far. But now, since we have so much experience over years, consensus document has been published and this is what they recommend. If you think that if the patient is on an agent which has association with type 1 toxicity like doxorubicin, you want to get baseline evaluation which includes troponin and the echo. If they are negative, you have two options. You can continue the therapy and follow them after the therapy and at 6 months and do the evaluation including echo again. That's what we do at our institution. We do baseline echo, they go for therapy, repeat after therapy, and at 6 months, that's what we do at our institution. But again, there are no guidelines, so every institution have their own protocol. What this consensus document is recommending that we should start with the baseline and then no follow-up until the dose is more than 240. Once the cumulative dose is more than 240, you start monitoring again with baseline echo and troponin, and particularly before every 50 extra dose you give. So up to 240, nothing. After that, any extra 50 dose you give, you should check before you give that 50 extra dose and continue if they're doing fine. But if, let's say if they have some problem to begin with, even before you at the baseline you have problem, then you might want to sit down with the patient oncologist and have a multidisciplinary approach. Find out how many high risk factors they have. Are there any other options? Does patient really need this? And do we have choice? Do we have no choice besides anthracycline? So you can sit down, talk about it, and make a decision. If it is really a bad EF, then you might not want to do it. If it is moderate low EF, and if really patient needs that drug, you may consider that. Because there are no guidelines out there. It's a clinical judgment after talking to patient, oncologists, and cardiologists. But that's going to be high risk. You might want to monitor frequently that patient, not like we do for otherwise baseline echo is normal. If patient is going to get type 2 toxicity drugs, then you do baseline. If it is all looking fine, then you can follow every 3 months on therapy. If it is abnormal, then again, you have to sit down, talk about it, make a clinical judgment, how you want to approach this. Do we really need this drug? Do we have another option? If you need this drug, how are we going to monitor this patient? And stuff like that, you have to talk with the patient. It has to be a collaborated approach to deal with this. What else can you do besides this non-invasive, non-invasive echo and the troponin evaluation? What else can you do? Well, if you are using anthracycline, your goal has to keep the dose less than 450. You really want to not go higher than 450. Use continuous infusion rather than bolus. They have shown that if you use bolus, it's more likely to cause toxicity. If you use continuous infusion, it's less likely. Radiation dose. If you are using radiation along with his, you do best to minimize the radiation dose. You can have an option of using liposomal formulation. They have less toxicity compared to the traditional one, but at the same time you have to worry about cost. There are some issues with the skin reaction because of it's a different drug, and also the efficacy has been questioned. So it is not routinely also practiced in most centers, but it is an option. Other option is to use analogs, for example, epirubicin. But again, there's a question about efficacy. The traditional ones are more stronger when it comes to treating cancer. Iron chelating agent is called dexrazoxane. Some institution use it, we don't use it at our institution. It's iron chelating agent. What it does is reduces the free radical coming out of doxorubicin and reduces the myocyte damage. But it's been only tested in advanced breast cancer patients, and also there was some question whether it maybe affect the efficacy of doxorubicin. So it's not used on all, widespread in all centers out there. Once, as we discussed, once LV function is there, you got to stop drugs, start therapy. Trastuzumab, consider sequential therapy. I talked about this before. If you want to use both together, you might want to give anthracycline first and then use trastuzumab rather than other way around. And once you have a toxicity, you got to stop drug, treat them, see if it reverses back, and then talk about restarting if you have to. So these are the few things you can do, but unfortunately, none of them is completely successful. That's a major problem. So you have to use combination of few things to reduce the risk. There's nothing out there that can make risk 0%, because all of these are different, used in different ways in different population, small studies, so you cannot put them together and make a specific guideline out of that. So you have to use clinical judgment and probably maybe combination of few things to reduce the dose. So those patients, those here, this is the group you might have to consider those options, combination of few options out of this chart. Okay. So once you have established LV dysfunction, what can you do? Well, the way we treat them is by starting oral vasodilator and beta blocker. And the commonest one is the ACE inhibitor and the CoREG. You can start with lowest possible dose, which is 2.5, and gradually increase to 20 milligram when it comes to ACE inhibitor. When it comes to CoREG, you can start with 3.125 2 times a day and gradually increase to 25 2 times a day. That's what they did in this study, which was published 4 years ago in JACC. And they found that if you start you got to start as quickly as possible, because if they're going to recover, they're going to recover within few months. So if you miss a board and if you start late, they may not recover. There is permanent damage, it's all established, and now therapy would not work. So most of them who recover, they recover within few months. So you want to pick those patients as quickly as possible, stop the drug and start therapy. And in this, out of 209 patients, 85% of patients, they were responder. And the definition, we talk about it. Some were non-responder and some were partial responder. Both those groups don't do well, unfortunately. So the one we responds well, those are the one you need to go after, start therapy as quickly as possible, up titers as quickly as possible. If you miss a window period, that person may not respond well. Okay. So how about other drugs? We talk about the cardioprotective strategies for the two main drugs, the anthracycline and trastuzumab. 5-fluorouracil, we said it causes more acute chest pain syndromes. If that occurs, you stop therapy, treat them for ACS, and avoid re-challenge because that will lead to a problem. Prophylactic therapy is questionable, no data, strong data out there. Paclitaxel, most of the time, the one that we worried about is bradycardia. Usually it's transient, occurs with initial doses, and it goes away by itself. You don't need specific therapy. Once in a blue moon, you may need someone. You may have someone who continues to have significant bradyarrhythmia in spite of you stopping the drug, and that person may need a pacemaker. But most patients do just fine. Continuous monitoring is not required. If it's going to occur, it's going to occur within an hour or two during infusion. That's when you need to monitor. After that, they are fine. Cyclophosphamide, as I said, it causes pericarditis plus or minus effusion. You can treat them with NSAIDs plus or minus steroid. Rarely someone needs anything more than medical therapy. Sunitinib is the one, the tyrosine kinase inhibitor we use for testicular cancer. It causes hypertension and LV dysfunction. The hypertension is very interesting. The hypertension that this drug causes is very notorious to be high grade, I should say. It requires 2 or more than 2 medical therapy antihypertensive to treat that blood pressure. Once the drug therapy is over, it usually comes down too, so it's reversible. It's not an indication to stop therapy. If you start medication and they go into grade 3, 4 hypertension, that doesn't mean you have to stop the therapy as long as you can control. If they develop really an end stage, end organ damage, encephalopathy, seizure and all that, then you may have to consider. But usually, in most patients, you can manage with medication. You don't have to stop the therapy. But if there is an LV dysfunction that you're worried about, then you have to stop therapy, monitor, start medications, ACE inhibitor and beta blocker, closely monitor them. It's questionable you really want to re-challenge them with the drug if the EF improves, particularly with this drug. And most oncologists would not prefer to re-challenge patients when they have LV dysfunction. Okay, so in summary, cancer patients receiving chemotherapy have increased risk of getting cardiotoxicity. particularly if they're getting those agents, the Anthracycline and Trastuzumab and tyrosine kinase inhibitors. Asymptomatic decline is quite common. That's why we need to monitor them before they go into clinical heart failure, because you may miss the boat, particularly with anthracycline. Non-invasive monitoring is the key, is the modality of choice you want to do, particularly echo, to recognize this toxicity. Patient at high risk should be considered for frequent monitoring as we talk about it. If you have no alternatives, you decide to give the drug, you need to monitor them very frequently and use all those possible cardioprotective strategies out there. After diagnosis is established, start the treatment with vasodilator and beta blocker as quickly as possible and stop the drug. All right, I think I stop here. Any questions? Yes?
The patients have malignancy. Are there any guidelines, or have had malignancy? Are there any guidelines as to whether they ever are candidates for heart transplant?
There are no guidelines for that. Have they considered that? I doubt, particularly with anthracycline, because if the cancer is there, cancer plays a big role when you treat those patients. So routinely not considered for transplant. Okay. All right, thank you.